Hi, I'm Dr. Ushma Bhojani, a women's health physiotherapist and a clinical instructor for invasive pelvic floor rehabilitation for WOW IIPRE. This case report aims to show the effectiveness of physiotherapy management in a 49-year-old patient diagnosed with stress urinary incontinence. Urinary incontinence is defined by International Continence Society as an involuntary loss of urine, which is objectively a demonstrable social and a hygienic problem. There are three main types of urinary incontinence: stress, urge and mixed. Today, we will be preliminarily talking about stress urinary incontinence. The stress urinary incontinence is a complaint of involuntary leakage of urine on effort or exertion. During effort or exertion, the intra-abdominal pressure increases and the urethral sphincter is unable to maintain the pressure higher than exerted on the bladder. Subsequently, the urine leakage occurs during everyday activities like lifting, laughing, jumping, sneezing or even coughing. Today, I will be sharing an interesting case of a 49-year-old woman, homemaker, referred to us with a primary complaint of urine leak on sneezing, coughing, laughing and exercising. Her day-to-day routine included heavy household work. Her coital activity was 7 days a week since many years. Used to wear panty liners for 5 years while going out to prevent accidental wetting. Last 2 years, she had her symptoms worsen and needed to wear panty liners even at home. She used to need at least 3 changes a day. Urine frequency in daytime was about 10 times. At night, the frequency was twice. Her water intake was about 7 to 8 glasses a day and had 2 cups of coffee a day. She had normal vaginal birth 26 years back with forceps assistance. Her labor had lasted for around 30 hours. She had also undergone DNC 25 years back. She used to do yoga regularly and used to experience leak during the same. For assessment, patient was thoroughly explained the basics of pelvic floor muscle anatomy and physiology. Was explained that transvaginal assessment will be done and a written consent was taken for the same. On perineum observation, we could see mild skin darkening as well as wrinkling at the perineum and around the groin area. This was due to sustained wetness. No abdominal tenderness or bloating was noted. A mediolateral episiotomy scar was seen, which was small, healed and mobile. She had no dermatomal abnormalities at S2 to S4. On dynamic assessment, there was no accessory muscle use. On making the patient cough, the perineum movement was outward with a frank leak. On Heath's MMT scale, her pelvic floor contraction was grade 1. The endurance was just 1 second with 3 repetitions. The fast twitch muscle score was 5 repetitions on 10 seconds. On Heath's ring clock assessment, no palpable movement was seen at 11 and 1 o'clock. 3 and 5 o'clock were comparatively weaker than 7 and 9 o'clock. On Heath's functional muscle testing scale, she was at grade C, and on Heath's female sexual dysfunction scale, she was scoring 31 out of 50. Post-treatment on discharge, she was able to activate and isolate pelvic floor muscles. On coughing, the perineum movement was inwards with no leak at all. Her pelvic floor muscle contraction was now at grade 2, which is complete circumferential grip. She was now able to hold the contraction for 8 seconds and 10 repetitions. Her fast twitch muscle score was 10 repetition in 10 seconds. Heath's functional muscle testing scale was now grade A and her female sexual dysfunction score was now 48 out of 50. Treatment protocol included making the patient aware of pelvic floor muscle with explanation and mirror biofeedback technique. Use of PF360 modality with shaft activation, targeted strength and hypertrophy training, and endurance training modules. Manual therapy was used to isolate the weaker area and give targeted strength and training as per the Heath's ring clock assessment. Neck technique was taught to train with the activities causing increase in intra-abdominal pressure like coughing. IFT was used for activation for the nerve fibers. Home program was given with help of Vagina Fit. On discharge, patient had no complaint of involuntary urine leak with any activities. Patient was followed up at 6 months and 1 year post-discharge. She had maintained her dry state, was advised to continue the home program and a 3-year follow-up is awaited. Outcome of the study is conservative management is the first option for patients with stress urinary incontinence. This case report shows that the successful management of a patient diagnosed with stress urinary incontinence following a patient-specific physiotherapy treatment plan. Although the results cannot be generalized, this case report highlights the importance of assessment and effectiveness of physiotherapy in management of stress urinary incontinence.